And yeah, now I'm going to see you guys all off because it's time for our next keynote. It was
Yep.
really great having you all here.
Thank
Yeah.
you so much. Yeah, perfect.
Thank you.
Yeah. So I think we all love discovering how, I think you guys have to, I can remove, um, I think we all love discovering how innovations are beginning to change the landscape of women's health and collecting novel female-specific data. Now, we're actually going to take an overview of how exactly male-centric medicine endangers women's health. And I'll just give you one brief example before introducing our keynote speaker. We touched upon briefly how historically women have been excluded from clinical trials, which means that most of the drugs we use today were not tested on women. Did you know that a woman's QT, so the time it takes from when ventricles in the heart start to contract to when they finish relaxing, is longer than a man's? And that many prescription drugs, so painkillers, antidepressants, antihistamines, antibiotics, cause incremental QT increases as a side effect, which means that the risk for women taking multiple medications, and statistically women are most likely to be taking multiple medications at the same time, can range from simple arrhythmia to sudden cardiac death. So that's a very clear example of how male-centric medicine endangers women's health by not factoring in the physiological differences between men and women. We're actually putting women's lives in danger. And on that note, we'll hear from Dr. Alison McGregor. Before I let her on stage, I'll briefly introduce her. Alison McGregor is a physician, researcher, writer, and advocate. She's a professor of emergency medicine and serves as Associate Dean of Faculty Affairs and Development at University of South Carolina School of Medicine, Greenville. Dr. McGregor was the co-founder and director for the Division of Sex and Gender in Emergency Medicine at the Warren Alpert Medical School of Brown University from 2010 to 2020, where her research on the role sex and gender play in emergent conditions has made her a spokesperson and advocate for women around the world. Dr. McGregor currently serves as a member of the Advisory Committee Research on Women's Health for the Office of Research on Women's Health, National Institutes of Health. She's a co-founder of the national organization Sex and Gender Health Collaborative and serves on the advisory council to the Sex and Gender Health Education Summit series, which is designed to establish an integrative sex and gender curriculum for current and future health professionals. She's published over 80 peer-reviewed publications in sex, gender, diversity, medical education, and women's health. Dr. McGregor's TEDx talk, Why Medicine Often Has Dangerous Side Effects for Women, currently has over 1.7 million views, and she has recently released her new book, Sex Matters, How Male-Centric Medicine Endangers Women's Health and What We Can Do About It, Hatchet Book Group Publishing. And on that note, Dr. McGregor, I'm going to let you on stage, and we'd love to hear your keynote. Do you need, yeah, your slides are there. Perfect.
Perfect. Great. Oh, Ariana, thank you so much. And I've been listening throughout the day for me. I'm not sure what I think it's in the evening for you, but really this is so important. I think that raising awareness is the first step towards creating change. And so I think you'll see a lot of similar examples throughout my talk. As that's been discussed here. So hopefully this will all make sense. So, as mentioned, my examples really come from the fact that I am an emergency medicine doctor. So I have been practicing emergency medicine for about 18 years. And that gives me this really interesting perspective because I can see the entire breadth of the human condition because it all just, if it can happen in real life, it winds up in the emergency department. So that's given me this perspective of bias if we were to really just reduce it down to this one word. And the bias has been really against women. And so when I see women patients come in, they're not just coming in for reproductive issues. They are having heart attacks and strokes and trauma and all of these really important conditions with high public health significance. So that really sparked my interest in this topic and to look at why is it that women are not winning at health? I thank you for mentioning I have a lay book, Sex Matters, and also a medical textbook, Sex and Gender in Acute Care Medicine. So I thought I'd just take you on a ride here to realize how this started. So I've heard lots of people mention that We haven't studied women, and that's very true, because when we started out, you probably remember in your biology classes, and this was pretty consistent even through my medical school training, men and women were considered the same, except for their reproductive organs. So, their hearts and lungs and everything else is the same. Maybe you have some secondary sex characteristics because your ovaries create and regulate estrogen, and the testicles will regulate testosterone, so that gives you hair and breast development. Other than that, we're basically the same. These aren't translating very well, but it's okay. So, the truth really is that men and women are not the same in the face of health and disease, and we can see this every day. 78% of all autoimmune diseases occur in women, not men. Men are 30 times more likely to die of sudden cardiac death during exercise than women. We now know that heart failure, so just the response of the heart muscle against high blood pressure, is different between men and women. Women get all these syndromes, these chronic pain, without really understanding what the cause is. So this has really, been something that we're understanding at an exponential degree right now. The research is wonderfully and overwhelming. But because we had really thought that men and women were the same, we studied men because they were easier. They didn't have the menstrual cycle to worry about. Women were considered a protected subject. And so the only time we really researched women was to look at things we couldn't study in men. So their breast development, their menstrual cycles and giving birth and menopause. So then we studied those things in women. But what happened was we really sort of reduced all of our health knowledge and information and evidence for women into only those issues. So by trying to protect women, we really did them a disservice, because we didn't really understand anything outside of the reproductive issues for women. What did that do? What did that do for women in particular? Doctors think that they are practicing evidence-based medicine. On the last panel, it was mentioned how long and arduous it is to do a research study. It can take upwards of 10 years and millions and millions of dollars to get one drug through the system to be approved. And so when we think about that, we think about, well, what is our evidence based upon? When 76% of cell-based researchers do not know the sex of the cell they're working on. They don't know if the sex chromosomes are XX or XY, which respectively is female and male. 80% of our animal-based research are male animals. Human clinical trials, yes, we are bringing in more women than we have ever before, but we're not analyzing the data to determine if there are important differences to actually utilize in the clinical care setting. Women make up over half the population, and women are the healthcare deciders for their entire family most of the time. And so how generalizable is this evidence that we've collected over this, decades? How generalizable is that to the patient in front of me in the emergency department? How generalizable is that to women? And it turns out it's not so much, because you just look at something like cardiovascular disease. Let me remind you, this is the #1 killer for both men and women. But women seem to have a higher mortality rate than men. Women are less likely to be diagnosed with a heart attack. They're less likely to be treated with evidence-based medicines. They're more likely to die before they leave the hospital than men. But most women think that they should be concerned about breast cancer. Yes, breast cancer is horrific. However, the #1 cancer killer for women is lung cancer. There's this lack of understanding of all of these other diseases that we could really get a hold of, and it can affect our livelihood. What's contributing to the higher mortality rate, additionally, is that we are still teaching healthcare providers that this is what a heart attack feels like. It feels like a white male clutching his chest and describing it as an elephant sitting on his chest. That is still being taught today. That is not how many women present with heart attacks. Women will say that they've been tired for weeks, that they are dizzy or nauseous, or they're short of breath, right? So this is not recognizable to the healthcare system. This is not recognizable to women. Women are still being told in a public health message that they should be looking for chest discomfort and chest pain, radiating down the left arm. So they're delaying seeking care. And then the ambulance driver, doesn't think that they need to rush her to the emergency department. And then the triage nurse isn't recognizing that this could be a heart attack. And then the doctor may not recognize it. So this is really sort of threaded throughout our system. And then what happens is we tell the women that this isn't their heart, that maybe it's all in their head, that maybe it's their anxiety. So this is what women are hearing. They're really feeling like the healthcare system doesn't get them, and it hasn't for a very long time. And just to show you that this is an international issue, the Women Inc. In the Netherlands had this ad in 2015. Treat me like a lady. Healthcare is based on the male body. And so that's really critical for us to understand. And so why is it important? Is it really that important? Well, when you think about what's happening inside your cells, when the sperm and the egg come together and they decide which sex chromosomes you get, XX if you're female, XY if you're male, those chromosomes, they're in every cell in the body. They're not just in the ovaries and the testicles. They're in the liver, and they are affecting the way that we metabolize drugs. They're in the heart. They are affecting the way that we develop disease. They are in the kidney. They affect the way that we are excreting medications. Something as mundane as Tylenol, men actually will filter out Tylenol 22% faster than women. Does that matter? Well, it matters if you're also, men are excreting beta blockers and all these really important cardiac drugs and all of these, drugs at a faster rate. And so we're not changing the dose of the medications like we should. We're still basing our dosing on men. We have those, chromosomes are in the stomach lining. Women have slower gastric emptying times. They have slower intestinal transit times. This affects metabolism. They're in the lungs. If women were to stop smoking, their lungs repair quicker than if men were to stop smoking. You have different concentrations of COVID-19 receptors in the lungs, and they're in the brain. And that's a very interesting, complex arena. Maybe the difference between men and women is because of the hormones that we have really ignored. We have studied men in their 20s, 30s, and 40s with stable testosterone levels because researchers wanted to find out what's really going on. And they thought that it would be too complicated with a menstrual cycle to consider the effects of estrogen. And so they did. They found out what's really going on in men that are 20, 30, and 40 and white. We haven't really understood how important these hormone levels and changes affect our body. We are now. For instance, there are many women who have epilepsy and they have seizures. And so they're on medications to prevent seizures. And when I see them in the emergency department, what happens is sometimes during the menstrual cycle, during the luteal phase, the concentration of that medication will drop. And so the woman will have a breakthrough seizure. And instead of targeting and tailoring her medication regimen to increase it during certain parts of the menstrual cycle, we either just increase it across the board, or we tell women they can't drive and they have to follow up the neurologist. There's really important distinctions that we can make. And then we live in a gendered environment. And it's not always very visible. So now that we have a spectrum of gender, there's lots of ways in which gender can affect our health. For instance, my trauma rooms are always filled with men because we expect men to do the hazardous things of the community, to get on roofs and to do things that are risky, and they do that naturally anyway because of the testosterone levels and social interactions. Women are, for instance, women in an area where they wear burqa, so then when they're covering their skin, and that's a socially gendered societal thing in different cultures, that's going to decrease that woman's skin cancer rates, but it's also going to decrease her vitamin D levels because sun exposure helps create our vitamin D. So these things really do matter, and we haven't considered them in our research. So getting to the heart of the matter for this particular summit, right? So modern health technologies, this is really where I think so many people who are interested in this and who are on this summit can really make a difference, because there's systemic bias already in the system. First of all, I have bias, right? I was born by a particular family and raised by them. I have bias in because of my teachings and my, the mentors. We all have bias. This bias has been built into our technologies as well. Think about wearables and our smartphones, and if we're tracking our heart rates, are we considering the fact that women may have different ways of reacting towards, exercise? As we are getting more and more advanced in our technology, we have to keep in mind that a lot of times they were tested on smaller smaller representatives, so smaller perspectives, so maybe just a sample of people. But what can happen is that can exacerbate underlying health disparities, right? Because then you're now expecting this technology to go out there and to be used by diverse populations and across the globe, and so it may not translate. One really interesting study that I find fascinating is this looked at smartphones. So they looked at a collection of smartphones and they asked it two different levels of questions. So they said, physical questions or women's health related questions or mental health related questions. And so when they asked, hey Siri, my Siri just went off. Hey Siri, I have a headache. I'm having chest pain. What should I do? And then the AI smartphone would say, well, the nearest hospital is here. Would you like me to call your doctor? It had very, very established recommendations. But when they asked it, I'm depressed. I was raped. I was assaulted. There was no content to be delivered. And the authors here surmise that a lot of this technology has been built by men, and men consider men, and women will consider women. And so, if you don't have diversity in STEM, workforce, then the products are not going to be applicable to diverse populations. Someone just mentioned blood testing and reference ranges and biomarkers. Those were established, a reference range. So of what's considered a normal blood level was established in men. And so it doesn't fit. One really powerful example of this is with troponin, which is an enzyme that when you're having a heart attack gets released into the blood, and we can measure it. And so what we did was science and health, they said, okay, well, if your troponin level is above a certain number, that means it's a heart attack. And if it's below that number, it's not a heart attack. And so that specific arbitrary number was based on how men have heart attacks. And so what happened is people thought, well, women have smaller hearts, and they develop disease differently. So what if we change that cutoff and made it lower? What happened was it really identified all of these women as having heart attacks that weren't identified before, just by changing the reference range to include women's physiology. Now, before that happened, these women were told that they weren't having a heart attack and that they should, see their psychiatrist or go see their gastroenterologist or go see their rheumatologist, right? Or it's all in their head. We're now identifying much more women with heart attacks. Our education systems, we give these textbooks and these all of these computerized educational materials to students, to medical students, right? And so what happens is that, gender bias in medical textbooks has been everywhere. My anatomy books, and still to this day, they're basically filled with the white male model, and then some women some pictures of images of women for their reproductive organs are sort of stuck in, a particular chapter. So we are taught to recognize anatomy and understanding through the male model. And that's not consistent with the patients that I'm caring for. And that's how I was taught. So this is an interesting look at all the COVID-19 skin-related publications. And they looked at it all, and they showed that almost all the publications had light skin tone. But not just white and light skin tone people have skin manifestations of COVID. And so we don't get to learn what it looks like in diverse populations. And it's still happening. I was just asked to review some review material for medical students to pass their boards, and I did. And this is their images for a heart attack, and you can see again a white male, sweating, balding, crushing his chest, clutching his chest. This bias still goes on, and we have to really sort of understand how this happens. And then we look at other ways where bias is inserted, and that is like the electronic medical record. This paper really sort of sums up a lot of interesting aspects for me, which is that this is pharmacists. They came together and they said, well, what if someone is transgender and they're on hormones, right? So if I said like, okay, so sex, biological sex, DNA, hormone levels, and then gender identity really matter, what if we were to shake that up a little bit? And so what they did was they looked at cis males, cis men and cis women, and then they looked at transgender men and transgender women on hormones, and they looked at their ability to excrete medications. So we call it the creatinine clearance. So how is their kidney excreting this, and how quickly, or what's the time frame? And they discovered that if someone who was transgender was on gender conforming hormone therapy for 6 months or more, they actually excreted the drug more like the gender that they are transforming into, or that they're affirming into. And so that's critical. And that's something that we could collect in electronic health records, and we can have doctors be able to change the dosing based on your biological sex, based on your gender identity, and based on your hormone profile. All of this is missing right now, when it's seen to be quite important. And then there's individual bias. So all of our individual bias. I was just at a conference and we were presenting, and we all started with, hello, my name is Allison and I am biased. I think that awareness is really critical to start to look at, well, where are my biases? And so what's fascinating is we're looking at now a lot of the gender of the physician, and how that relates to the outcomes and whether the patient is a man or a woman. And so for surgical, this particular surgical study looked at when the surgeon was a woman and the patient was a woman, the female patient did better. And when the surgeon was a man and the patient was a woman, she had higher adverse postoperative outcomes. What outcomes? Higher rates of death, higher rates of complications and during surgery, higher rates of readmission. And so does that mean that women surgeons are better than men surgeons? No, not necessarily. It could just be communication styles. We do know that women are more likely to follow particular guidelines, but also maybe if you're speaking and communicating with someone of your same gender, someone that looks like you, maybe you're more likely to take the advice that's given. Another example is of heart attack patients. So they found that when the physician was a woman and the patient was a woman, they had greater survival when presenting with a heart attack. So that's really incredible. And that's not small, obviously. And so we have to sort of really look at when we see differences and why differences in outcomes, teasing it out to look at why so that we can create necessary programs and guidelines and protocols in place. Again, making sure that women are sitting at the seat. They found this particular study looked at the textbooks and looked at the pictures of the textbooks. And the textbooks that had women editors were more likely to have female pictures in the anatomy books. So this tells you that there's a connection between both sides of this on a public health degree. It's not just about making sure that patients are cared for sex specifically, but also that in leadership positions, in scholarship, in technology, in science. I'll finish with some of the solutions, right? Some of the solutions are fixing this bias. Why does diversity matter in science and tech these days? And so this particular journalist says, because a homogeneous team produces homogeneous products for a very heterogeneous world. And so that's critical. And so there are some real heroes that are out there that are starting this. And I think we've just heard from a bunch already of our speakers are the heroes that are fixing this, that are creating products that are fair. And this particular medical student found that his anatomy books did not have any pictures of people of color. And so he wanted to know how to care for people of color. And so that requires this being part of the educational process. So he created his own book. This particular medical student on Twitter does medical illustrations on the side. And when I saw this, I was like, I can't believe I'm so shocked. This is the first time I've ever seen a woman of color, a baby of color. It's incredible, and we need to have more of that. I think as you are building this technology, please keep in mind that vocabulary words matter. So our medical system has really looked at women as a subgroup of men. So we've looked at everything as what the typical symptoms are. If someone says, what are the typical symptoms are? It's usually because that's what's typical in men. And then we've looked at, oh, well, women are atypical. They don't present the same way as men when having a heart attacks. But now that this evidence is really, expounding, we should really be making sure that we decide to say that something is typical for men, or it's typical for women, and then reserve the word atypical for any variation from that. So we have to really incorporate these differences in our language as well. So that way we have that sort of fairness. And this happens again in science. This particular researcher looked at 1.5 million research papers. And when the author, the first or the last, which are the two most prominent authors on a study, when they were women, the women were more likely to study gender and sex-specific analysis. So women were thinking of women, they're enrolling women, and they're analyzing it to determine differences. When we're enrolling people in clinical trials, if you have white men enrolling white men, that's that's where are you going to look for diverse populations to enroll? Maybe we need women to enroll women. Maybe we need to go to communities where there's diverse cultures, and to make sure that those those that are enrolling folks into clinical trials actually are diverse as well. So it can establish a trust issue. These are some of the solutions. And I think from the health perspective, which is my perspective, diversifying the workforce is one really solid solution to get this going. And I think that what we've heard, in Fem, and, we just mentioned FemTech. And I think it's really incredible that FemTech was new and started several years ago. And someone could probably say when that term was coined, but it's also been very heavily based in the beginning on reproductive health. And so I love seeing that now it's broadening to all technologies. If it's around health technologies, making sure that there are specific health technologies for women as well as for men. I will stop there. You can follow me on Twitter, Facebook, and Instagram. I don't know if we have time for questions, but I'm happy. I have a few minutes, and I'm happy to stay.
I think that actually the time for the keynote is up, but I'm sure that on the platform they can message you directly with their questions, and actually, But thank you for that amazingly insightful keynote. It was truly enlightening, and to your point about how it's still not being incorporated into medical education, I was actually having a conversation with a fellow medical student in the year above who was saying that still today on the slides they only show the symptoms of the way heart attacks manifest in men, as like a little asterisk at the bottom of the slide they say, but remember it manifests differently in women, which is insane because it's 50% of the population. But yeah, thank you. Yeah, thank you so much for coming and for speaking to us all. And yeah, I would encourage you all to connect with her on the platform. I'm gonna slowly wrap up the panel portion of the summit before we move on to the speed dating. So to recap, today we discussed the future of fertility, what it looks like when women are able to take control over their journey and are armed with the information they need, and the implication discoveries of infertility might have for health later down the line, not just reproductive health, but general health. We discussed the imperative for investing in women's health research, stretching beyond the ethical imperative to an economic call to action that's hard to deny. We then talked about how novel biomarkers of women's health can be incorporated in the future, and what we've been ignoring by neglecting these data sets, what we might be better able to learn about correlations in women's health by exploring these innovations. And that was just day one of the FemTechnology Summit. We'll be back tomorrow, and I see that a lot of you keep signing up. We're up to 1,500 registrations, which is great, and a huge thank you all for joining. We're thrilled to see you from all around the world. The speakers were amazing. I hope you'll join me in giving them a huge round of virtual applause. But as amazing as our speakers and keynotes are, our audience is also fantastic and impressive in their own right. You've been the best attendees we could ask for, and now we think it's time for you to all get to know each other. So I'd really encourage you all to head over to the left-hand side where there's the little handshake button for the speed networking. Yeah, like I said, that concludes day one. We hope you had fun today, and we hope to see you tomorrow at 3:20 when we start once again for talks on sex-specific therapeutics, the link between gender and effective therapy in medicine, and the future of care. And don't forget, grab your chance now to network. See you tomorrow. Bye.